So we'll get started now with our introductions and everything. So good morning, everyone, again, and thank you so much for joining us today for our Social Determinants of Health Roundtable. My name is Rima Naik, and I am the Performance Improvement Program Manager here at Nevada Primary Care Association. So Nevada Primary Care Association helps community health centers provide exceptional medical, dental, and behavioral health care to Nevadans by advocating for them, supporting policy changing, providing training and technical assistance, and creating economies of scale through program management. For more information regarding what our Primary Care Association does, you can go on our website, nvpca.org. So before we get started, we wanted to go over some logistics and housekeeping for today's roundtable. So in the chat box, please type in your name and what organization you're coming from today. It gives us an opportunity to see who in our community is with us. During the presentations, please mute your phone or computer so we don't hear any feedback or background noise. And also, please do not put your phone on hold, or then we'll hear your hold music. And you'll have an opportunity to submit questions at any time throughout these presentations, and you can type them into the chat box. So with it being a roundtable discussion, we ask you for engagement throughout the various polling and discussion prompts I will give to you after we hear from Hope Christian and Community Health Alliance. We encourage everyone today to learn from one another and discuss any successes and barriers to social determinants of health integration at your health centers. And at the end of today's session, you will be directed for a quick evaluation. So please take 2 minutes of your time to complete it because it'll help us better serve you. So with that shared, let's dive into quickly reviewing the learning objectives. I'm just keeping this on the slide, but overall, we are here to discuss what social determinants integration is happening at our health centers throughout the state. And we're really lucky to be able to have representation from both Northern Nevada and Southern Nevada being spotlighted for today's session. And again, at the end of this roundtable, after we hear from our two speakers centers, we want to engage in discussion. So quick reminder, in the next slide, social determinants of health are those conditions where people born, where they grow up, where they live, where they work, where they age. And the Kaiser Family Foundation has found with recent research that social and structural factors, including education, race, social support, and poverty, do account for over 1/3 of total deaths in our country in a year. So again, we're here to discuss how our health centers in the state are supporting the social determinants of health of our patients to prevent early morbidity and mortality for them. So in the next slide, we wanted to quickly review some of where Nevada stands and where we rank compared to the other nations, or in the other states, I should say. So we pulled from several different resources like the American Health Rankings and also Feeding America to see where we stand. And so first things first, our state's one of the lowest spenders in public health funding, spending about $72 per person versus America's average of $116 per person. And this funding helps support many initiatives that are focused on public and community health. Our state also ranks low in education. And when we look at low education further, it's related to low health literacy for our patients. And low health literacy is related to poor health outcomes for patients too. And when it comes to our environment, we rank low in our air pollution as well. And as fire season approaches, it only becomes more of a concern, especially for our patients who have asthma or have respiratory issues. And now looking more into healthcare, we do rank one of the poorest in behavioral health services, vaccine uptake for patient populations, and we also have many different concerns over housing. Now with food insecurity, we have about 1 in 8 people in our state facing hunger and about 1 in 6 children facing hunger too. So these are just some of the reasons why we need to address the social determinants of health for our patients, especially for you as community health centers. And you know why. You're already doing this work too. Now we're going to explore and learn from 2 health centers. We're going to hear from Hope Christian Health Center and Community Health Alliance. And I'm going to hand it over to the Hope Christian Health Center team so they can get us started.
Well, I'm Steve Flores. I'm the CEO of the Hope Christian Recuperative Care in the city of Las Vegas. And after that last slide, all I want to do is go home and hide under the bed. That's we're pretty horrible here in Nevada. So hopefully our goal, especially with the recuperative care, is to have an impact on those kinds of things. To us, as we define recuperative care, it's about providing a stable environment for those experiencing homelessness to recuperate from illness and injury that are too ill to recover on the streets, but no longer ill enough for hospitalization or rehab. And that's a very nice way of saying that hospitals were releasing homeless to the streets where their wounds, illness, wounds would get infected. They'd end up back in the hospital. Prescriptions given to them, meds given to them to help them heal would be lost or stolen. And then once again, get in the way of healing. Our recuperative care, the number one reason for its existence is for the homeless to have a place to heal. But it was also the desire of the city of Las Vegas and Hope Christian Health Center to not just babysit, make them well and release them, but to impact all of the healthcare for them, which means we also do primary care services there. We set up referrals. They may be in there for wound care, but maybe they're diabetic or maybe they're hypertensive. We provide the care, and the goal is that when they do leave, and just over 50% are actually being released to permanent shelter, that if they do leave, when they leave, they're healthier when they came in, and they're set with meds, and they're same with follow-up to another Hope clinic half a block away from the recuperative care. The other part is, oh, perfect. Thank you for pulling that up. So we're looking to reduce the hospitalization, return to hospitalization. We're looking to improve in the healing process and the overall health care. We provide coordination, we provide wraparound services, we facilitate access to comprehensive support services. So what that really means is we help them get their IDs, we help them get their insurance. We make referrals, and I believe, and I think Dr. Cruz will speak to this later, is just since January, we've had over 160 referrals to specialty services. But we don't just send them, we transport them to make sure they're there. We get the results back so that we're always working on the right thing with them. We have social workers helping with many things. We have patient navigators, we have transport, all working there. And for 4 days out of the week, we have a primary care provider there. Actually 5 days out of the week, we have primary care there to see these patients, to follow up with these patients, to build the relationships with them, and what we do. And if we do well in building a relationship with that patient, they'll come back to either RCC or to another Hope clinic where they know that we have access to all their medical needs, everything that we've done in the past, as well as knowing that we're going to care for them. So Hope, during the pandemic, we knew that patients were afraid to come to the clinics. Everybody was telling them stay home, but we didn't close our clinics. We didn't cut everybody over to telemedicine, only those who wanted to. So we went to the streets. We went out with a medical unit, and at that point staffed by Dr. Galvin. We went out to high schools to communities to consulates, and began seeing patients where they were. And then as time went on, we created a reputation of saying yes to helping the neediest, to helping those who had the least access to healthcare. We were approached and asked if we would be willing to be the operators of the recuperative care, and we said yes. Dr. Galvin and Summer will talk a little bit about that process in just a second here. Also, Hope Christian Health Center, we're faith-based medical care. So, of course, number one, we do all the science-based medicine care. However, patients know that we will offer prayer, that we will pray with them, that we will pray for them, that we believe that in our hearts that Jesus Christ is the greatest healer. And so we complete with more of a whole care. So it's not just the science, but it's also knowing that we're going to share with them our hearts, which should be a heart of God, and that we're going to care for them, and we're not going to do hit and run jobs. We're not going to see them once and not go back, that we will always be there for them. And in doing so, and in going to different outreaches and to helping the schools, helping the students, helping their families, helping their siblings, we began to earn a trust with the community, and that's led to all the things that we do now, beyond being unique to RCC. So with that, I believe the next slide, I think it's going to be Dr. Galvin talking about this process took almost a year and a half from the day we started working on it to the day we took over, which was January 1 of 2022. And on day one, we were seeing patients and bringing the additional primary care services to them.
Good morning. So development of this program was totally brand new to us. None of us had ever heard of respite care or what that is. So the first thing we needed to do is determine and define what the scope of service and practice was. And this is where it was hard for us to get our minds around it, because respite care is kind of in this gray area between outpatient and say like a skilled nursing facility or rehab. So it's not intended for intense rehabilitation or care, for example, care that needs a current round the clock IV therapy or enteral feeding or things like that. So the patients in respite care should be recovering from surgery or an acute medical concern or an acute exacerbation of a chronic medical concern. And the purpose is to help the patient increase their independence in caring for their medical issues and establish them with primary care for their ongoing health needs as well. So as this has a lot of benefits. I mean, first of all, it reduces likelihood of readmission, like Steve alluded to, reducing local healthcare costs. It increases the patient's readiness to care for themselves, because some of them do have complex medical issues that are complicated. And it provides an opportunity also to engage them with social services and hopefully get them off the street. So this does include basic wound care, medical education, medication education and supervision. You know, we can check blood sugars, basic labs, we can do EKGs, they can bring in a wound care nurse if needed. And then the nursing and CNA care is more along the lines of, you know, minor assistance with ambulation and transfers and bathing, though the patient should be mostly independent. We also provide meals for them, which are provided by the Culinary Academy and can actually be tailored to specific dietary needs, like a cardiac diet or a diabetic diet. So the admission criteria and restrictions is the patient has to be pretty much independent with ADLs, eating, toileting, bathing, except for minor assistance. There are some exceptions to this. I mean, every patient is different, but that's the general rule. They need to be overall medically stable. There no actively psychotic or unmanaged psychiatric diagnoses. And then at a minimum, there's a screening and requirement form for the hospitals detailing these restrictions. So best practice is actually to have an intake specialist go out to the hospital or somewhere or somehow do a face-to-face with the patient to make sure that the patient that arrives is actually the patient we were told about. But at this point, you know, at the bare minimum, there needs to be at least a screening form. They also can be admitted from one of our clinics, or from the street medicine team or clinic at the courtyard who feels that like, hey, this patient isn't really bad enough to go to the hospital, but they just need a little extra attention to get this their medical issues kind of back in control. The patients also have to be willing to sign a contract that they'll participate in their care and they'll abide by the facility rules. So handling of emergencies, all of the staff are trained in BLS. There's an AED and a limited crash cart on site to handle things like allergic reactions, the initial treatment of a suspected acute coronary syndrome, and that's all while 911 is being called to come and take the patient to the hospital. Obviously, 911 is immediately called for any unresponsive patient while we start CPR. Police or 911 is called for any violent or significantly disruptive patients, you know, if we think that there's a safety issue that can't be handled. But it is not an ACLS facility. We don't have an ability to intubate people or start a central line or anything like that. Transitioning the program from the city of Las Vegas to Hope Christian Health Center. Well, the city of Las Vegas launched this respite care very quickly as an offshoot of the response to the COVID pandemic, when they were trying to find a place to quarantine homeless who might be COVID positive and treat them and things like that. So the emergent nature of this launch meant they kind of just jumped right in without a lot of foundation in place. So they reached out to us to come in and write a scope of practice and a budget and an operations plan and things, which various folks in our team here will talk about. So the scope of practice we wrote clinically was about 2 pages long, and really tried to just nail down the population and what we were going to be doing. So just because of various processes with the city, the way they have to bid out opportunities and things, we actually didn't come in and take over until like 1.5 years later, I think it was. So by then, the respite had already been functioning kind of with a, agency staff and things like that. Again, really without that foundation. So when we came in and Dr. Cruz took over as the medical director, there was a huge culture shift because we see this as part of Hope and as part of our unique mission, which is excellent medical care regardless of a patient's ability to pay. So we require in our clinics that our care has to follow the most up-to-date medical standards, and it has to be provided with compassion because in our eyes, we recognize that everyone is made in the image of God. So just because of our patients are homeless doesn't mean that they're less worthy of the best care. We don't do things because we're such great people and we want, morally this is the right thing to do. We do it because we know that God loves each of these patients as much as anyone else. And we want to make sure that they feel loved, cared for, and that they're receiving the best care. And we also believe in taking care of the whole person. So not only their medical needs, but their social and spiritual concerns, because that affects their overall health. So this required very rapid development of policies and procedures, because excellent care for us means that we're above board with all of our policies and procedures and our employee requirements. We don't cut corners. So we reached out to several existing respite facilities across the country to find out, how do you do things? We joined the National Healthcare for the Homeless Council and enrolled in their respite training course, which not only has helped us kind of work through a lot of these things we had never heard of before, but enabled us to network with other places who are in various stages of building or running a respite and share best practices. And so using what we've learned from others and our previously established Hope policies as a springboard, Dr. Cruz has been steadily creating a foundation of policy and procedures to guide every aspect of the respite operation, as well as create the culture of that we have at Hope, that everyone who works at Hope is there because they want to serve. Credentialing providers, all our providers are credentialed internally through our board of directors, as well as with the various MCOs that provide the Medicaid services. We also review all our providers on a monthly basis, a minimum of 10 charts a month, and they're required to maintain appropriate levels of continuing medical education, again, to make sure that they're providing the most up-to-date evidence-based care. That's all I got.
That's a lot. So I think now also we could introduce Summer, our finance director, we'll talk about all the fun we have with getting everything going, all the costs, the reimbursement process.
Okay, so what I'm planning to talk about is the development of the program from a financial standpoint and what those barriers have. The first thing is, I think that we received a City of Las Vegas grant, like both Dr. Galvin and Steve mentioned. This took about 1.5 years of preparation. While the National Healthcare for the Homeless does have several resources for the recuperative care, every facility is unique, and I'm sure, as you all know, developing a new program, you can predict and estimate as best as you can, but with the knowledge you have at the time. And so developing this and preparing the new budget, many months developed, and trying to look at the scope of service that Dr. Galvin had worked on, and then also determining like the equipment and types of supplies that were needed to develop this budget. Our grant from the City of Las Vegas is a reimbursement grant. So that means that sometimes it can put some cash flow constraints on it just based on the amount of reimbursement that we have monthly. And so that also has something to consider when it comes to the grant. We do bill for primary care services. We are unable to bill for respite care services, and that will be more here in just a few minutes. So uninsured patients, we work to see if they're eligible for Medicaid, and if they qualify, that we enroll them. But otherwise, the cost of recovery for our patients falls on HOPE as an expense. Which leads to the need for sustainable long-term funding, right? So the city grant is vital for us to operate RCC. As the nature of grants go, there's no real guarantee from year to year on how much funding you'll be received. And so obtaining stakeholders and donors and partnerships are a continual critical piece for our sustainable funding. And so overcoming financial constraints. As I mentioned before, we only bill for primary care services because that is the only type of care that we're currently able to bill. The reason is recuperative care services are unique, and it's not well recognized within the nation, and certainly not within the state of Nevada. We are the first recuperative care center in Nevada, which means our MCOs don't have billable service for this type of visit. And there's really only a handful in the nation that recognize this service, and organizations can bill for it. So with that, education is key on this whenever it comes to finances and building partnerships. And so what we would like to do is to start to educate our MCOs and our hospitals to develop those partnerships for the benefits of our patient care and for financially for us and for our MCOs and hospitals. Something that could benefit our MCOs would be to address their gaps in care, because that is something that is very important to our MCOs. And so that could increase that could better address the gaps in care for our patients and address the needs before hospitalization is necessary. I think the biggest thing with these two partnerships is that not only is it to help for us financially, but also for the organizations to also have safe financially in the long run. And so hospital partnerships, things that we would focus on would be reducing the readmission rate of the hospitals, which they are currently seeing. That results in lower costs and better patient care for us and the hospital, and to provide a location for a more ethical discharge. These are the things that we're looking forward to developing these partnerships and educating these organizations to overcome these financial constraints and develop more sustainable funding for this program. So if you could go to the next slide, Dr. Cruz will talk about the clinical piece.
Hi, everybody. I'm Ricardo Cruz. I'm the medical director at the respite program here. Wanted to discuss a little bit about our operation successes. Bearing in mind that we've just been in here since January of this year, we've seen approximately 99 patients admitted. So our average number of days here, at least patient stay, we've actually reduced the amount of stay because we are able to establish ourselves with consistent primary care services. We're able to provide increased attention to medical needs and medical stabilization of chronic medical conditions. Upon admission, when a patient is intaked, and I know this question was asked earlier, we don't have an RN as an intake specialist. Our intake specialist will begin a process, a procedure on intake that allows the patient to be brought in. Their belongings are put into a bin outside and locked and assigned a bin. The intake specialist will also assign the patient a bed. The patient will be bathed. Oftentimes we'll also prescribe them medication to help with any type of scabies or bed bugs or anything before they're actually put into where our patients sleep. And so that's what our intake specialist does. But a step before that, we receive referrals, and these are packets that we receive from either local hospitals, rehab centers, skilled nursing facilities that allow us to actually review the patient's information, their admitting diagnosis, their chronic medical conditions, their medications. We get a PT and OT evaluation as well. And so based on all of the information we receive, we make a medical and social determination if this patient is appropriate for the RCC. So once a patient is appropriate, we are then able to give the green light to the referring facility, and the patient is then transported here to the intake specialist. Once the patient is actually completed the intake process, which is on average about an hour to 2 hours, the patient is then actually handed over to our medical team, where our nurses are actually going to start stabilizing the patient, making sure that the patient's medications, if they come with medications, are locked within our medical area. And they also notify either myself or my nurse practitioner if we're in-house or on call for the medical admission. And that's all done quite consecutively. Each patient that we do admit is seen quite quickly. We want to make sure that once the patient is here, that everything is stable, not only with their medications that they're being admitted for, but also with any medications that we do carry for anything that may come up. The average length of stay, it varies. Now, prior to us being here, the average length of stay was a little bit, I mean, we'd have patients that would be here for 30 days, and we have a couple of patients here that have been here for 300 days. And so one thing that we've been working on is trying to reduce our level of stay without reducing the amount of quality of care or the safe discharge. And so with that in mind, because we are seeing patients consistently, we are also providing this preventative care management. So while patients are here, we're providing mammograms, we're providing, colorectal screening, pap smears. And so during that time, we also do work with case management so that case management can actually begin working on a safe discharge, a safe plan. And so since January, we've actually placed about 49 patients in housing, which, as you can see, is nearly half. And, placing housing is a very difficult situation. Not only is it based on availability, but it's also based on patients' medical conditions. Unfortunately, it's also based on any criminal record. And so there are a lot of barriers that case management has to work through for that. I saw this question, we are a 38-bed facility. we have 4 patient rooms for isolation. So even if a patient is in a hospital, but they have MRSA, for instance, we will still admit them. And we'll keep them directly into our isolation until they're cleared by MRSA, and then they can actually go where the rest of the patients are. We do average about 31 patients. We have been at capacity and sustained capacity for quite some time, but because we are discharging quite successfully, our numbers do drop. We've seen approximately 427 primary care visits seen here. Regarding referrals, patients do come. I mean, we accept them with nephrostomy tubes, with ostomy bags. We've referred out about 187. So we are consistently working with local specialties, and I've created a form that allows that the patient brings with them. It's a plan of care form that I created, so that they can actually bring that over to their specialists. A specialist, if I would hope that they would fill it out, would be able to provide us a little bit more of an up-to-date plan of care, so that we can actually make changes accordingly, because oftentimes in our primary care offices, it may take months before we hear back from specialties. So in order to help expedite this, I created this form. We've prescribed 617 medications, and much like Dr. Galvin had mentioned, when we've come in, organization and structure has been something that we've been working steadily on. Okay, Reba, can I have the next slide? Okay, some of the barriers that we're experiencing here, it's difficult to get employees. I'm sure we've all experienced the challenges we faced with finding good quality employees that are going to be consistent with the mission that we have at hand. Now, as it is, we are serving a very challenging population with not only their chronic medical conditions, but with drug and alcohol use. It's a very unique mission, and this type of care, although difficult, is highly rewarding. Another thing is the limited awareness. I'm often on the phone speaking with a lot of facilities, even hospitals, that are unaware of our existence. That awareness is slowly growing, and my goal is that one day a hospital or an emergency department will recognize that a patient is at risk for discharge and is homeless, and will think of the RCC first. Educating the population, of course, the population that we do serve doesn't take healthcare as a high priority in their life, just based on their circumstance. So education is a large thing that we are working on, and I'm currently working on trying to get dietitians, nutritionists, and mental health specialists in-house. House placement challenges I already touched on. Transportation limitations, as we're a 38-bed facility, sometimes 42, patients do need transportation, and we are limited by not only employees, but also by vehicles. Lastly, the MCO intentionally, we feel, does not do that, and I'll hand it to Steve.
Yeah, I don't want Dr. Cruz to end his great work on a bad note, so I'm going to say this. MCOs are very competitive, and they change patients' PCP, knowing that that patient has been seeing us, that the patient's care, the patient's medications are coming from us. When patients tell them, no, I don't want to go a mile away, I don't want to go 3 miles away, they still are being changed. So as we work with the MCOs in our area, and we know that we have 4, it is our challenge to let them know that it's still about continuity of care. I go back to the first graph that Rima put up, and we talk about being 48th, 49th, and 50th, and yet we still haven't gotten together when it comes to continuity of care. As an FQHC, as a faith-based ministry, somebody has to advocate for the homeless and come against people who intentionally get in the way of continuity of care for our homeless. So that's it. Dr. Cruz, Dr. Galvin, and Summer, these 3 have done just an incredible job in terms of all the time it took, all the hours of time, all the challenges faced, and still coming in loving doing what they've done. They've done a great job. I'm grateful for the three of you, as well as those who supported us through the city, the paramedics and other things that have been just part of fighting for the best continuity of care for the neediest population we have. If I could just, I would like Dr. Cruz to talk about, Dr. Cruz or Dr. Galvin to talk about the second bullet, the continued city partnership as a result of becoming the operators of the Hope Christian Recuperative Care. It's actually grown to other services in a facility called the Courtyard, which also turned into street medicine. And now the RCC, the Courtyard Clinic, the street medicine team are all now working together, and it's exploding in terms of identifying, working with partnerships. We work with the fire department, we work with the paramedics, we work with the MORE group, and of course directly with the city of Las Vegas, the team, CPLC assigned to the Courtyard, all incredible organizations with one goal. And that's to keep our patients healthy out of the hospital and overcoming some of the illnesses that they face each day.
Yeah, I just wanted to say, so I'm actually, we're working now with UNLV, the medical school, Toros Medical School. So we have students, actually, the medical students coming to actually experience this type of care that we provide here. As far as forward expanding services, I've reached out to the UNLV School of Dentistry to be able to come and offer dentistry here on site, mental health services as well. We do eventually want to partner with podiatry and psychiatry to maybe be able to offer those in-house services in the future.
Wonderful. Thank you, Hope Christian team, for sharing all this information. And it looks like we have a lot of excellent questions in the chat box. So if you can take some time to look at them and continue on the dialogue as we transition over to the Community Health Alliance and hearing from them, that'd be fantastic. I'm going to have Sandy take over the reins, and she'll speak more about what's happening at Community Health Alliance and how they are integrating social determinants of health in their health center.
All right, so my name is Sandy Hartman. I'm the Care Management Supervisor here at Community Health Alliance. And today I'm going to present on the services that we offer at Community Health Alliance, as well as how we have began diving into identifying and addressing social determinants of health. So our mission at Community Health Alliance is quality, affordable, comprehensive health services for all, no matter what. Our vision is to deliver compassionate, high quality, affordable healthcare, serve and advocate for those in need, and partner with others in the community we serve to improve quality of life. So Community Health Alliance is also known as CHA, is a federally qualified health center serving over 2,300 patients annually. We have 7 locations located throughout the Reno-Sparks area. So in each different quadrants of the Reno-Sparks area to provide access to care, with most of our health centers being on a bus route so that patients have accessibility. One of our locations also includes a mobile medical van center at Our Place, which is a women and children's homeless shelter, and we're there every Thursday morning. We provide primary care, reproductive health, behavioral health, chronic disease management, nutrition counseling. We have on-site pharmacy, and we also offer dental services for the homeless and our pediatrics. In addition, we're also the second largest WIC provider in Northern Nevada, and we also offer an on-site food pantry at both of our Wells and Sparks location. So in order to deliver our mission, we accept all insurances, and that includes Medicaid with all of our MCO plans here in Northern Nevada, as well as Medicare and Medicare Advantage plans. And we offer a sliding scale fee discount based on family income and size to all of our patients. We also offer services to our homeless patients free of cost under our grants. And we have on-site representatives to assist patients with applying and enrolling for Medicaid and Medicare, as well as Nevada HealthLink. As well as providing this care, we also participate in local community events such as the Family Health Festival to educate the public on the services we have available. And then we have also been able to get primary care physicians out doing blood pressure checks, and we're also able to register patients with a medical provider at those events so that we're able to get them into our health centers. In addition, we have 2 in-house pharmacies that offer 340B medication pricing and complimentary delivery at our Sparks and Wells location. With the complimentary delivery, we're able to break down that barrier of transportation to our patients that aren't able to come to our health centers. And then we're also increasing access to medication by being able to offer medication at a low cost. For example, when it comes to diabetes management, typically insulin, when it's a self-pay price, it's about $300, and we're able to offer it as low as $25 for a 30-day supply. We provide COVID-19 vaccinations and boosters at all of our Wells and Sparks locations, with also walk-in availability. In 2021, we administered over 10,000 COVID vaccinations in our community. We also hold back-to-school vaccination clinics, and we hold a mobile medical center at various different locations in town, offering the flu and COVID-19 vaccines, increasing access to those vaccines within our community. So here's just an overview of our locations. So we have our Wells Health Center location and our Sparks Health Center location. These are currently our 2 largest locations. At our Wells Health Center location, we do offer our medical, behavioral, dental services with pediatrics and our homeless, a food pantry, an in-house pharmacy, WIC, and an on-site Quest lab. And then we also offer COVID-19 vaccines and boosters to all. At our Sparks location, we offer medical, behavioral, food pantry, WIC, and an in-house pharmacy. And we do still offer the COVID vaccine and booster there, as well as the COVID antiviral to our patients and the COVID-19 antigen and PCR testing to our patients. We don't currently offer dental at the moment, but we are looking to begin that again. Our other locations are our North Valleys Health Center and our Neal Road Health Center. Those offer our medical, behavioral, and WIC services. And same thing with our Sun Valley location, but we are looking to open our newest health center this summer at Sun Valley. So it's going to be a larger location, and we're going to be able to expand our services to include food pantry and the in-house pharmacy at Sun Valley as well. And then we have our medical mobile van, like I mentioned earlier, that's at our Women and Children's Shelter, and we're there every Thursday morning. We have a community health worker that's dedicated to our homeless population that's out there, and they coordinate with our case management to ensure that patients are connected to the appropriate healthcare services. And the health center that I'm going to touch on today is actually our Center for Complex Care, which is where we started integrating capturing social determinants of health. So our Center for Complex Care opened in 2016. It's also known as the CCC. It's what we call it here at Community Health Alliance. So the CCC is a health center dedicated to improving healthcare experiences and outcomes through a patient-centered, team-based approach. The CCC offers collaboration between multiple healthcare providers, including primary care, behavioral health, and care coordination. At the CCC, the patients have 30-minute appointments versus 15-minute appointments where they would have at the other health centers, and they see their PCP on a more frequent basis. The CCC also has patients also have access to additional services such as clinical pharmacy and psychiatric therapy. So this is the team at the CCC. We have a primary care provider, and they are their main source of medical care. We also have a medical assistant, and they're able to perform routine tasks such as taking vitals, doing some med reconciliation with the patients, and informing them on their care. We also have community health worker and/or care coordinator, and they assist with care plans, arranging and tracking appointments, educating patients, coordinating all aspects of the patient's well-being, and then making sure that they understand their medical condition and other instructions. We have access to a psychiatric nurse that is able to perform similar duties to a psychiatrist by diagnosing, but also being able to prescribe medication if needed, and they are equipped to treat various disease diagnosis from mild depression to severe cases of mental illness. also have a licensed clinical social worker. So behavioral therapists work to support the emotional well-being of the patient. And so they also do mental health, substance abuse, family dynamic, daily stress, and various life-changing trauma psychotherapy. And then we also have a clinical pharmacist that works directly with the physicians and the other healthcare professionals to provide the patient care that optimizes their medication therapy. So they review all of the medications that the patients are on and ensure that they are taking them correctly. And they're really a vital point, especially with our diabetic patients, of understanding the importance of taking their meds and making sure that they are taking them on time. So as far as the timeline of the CCC and the social determinants of health integration, so in order for patients to establish at the CCC, they have to see a primary care provider outside of the CCC. So at any of our other locations, excluding our mobile medical van. So in the past, when it opened, the PCP would stratify patients from 1 through 6, depending on the comorbidities and the barriers to care that they had. So patients that scored 1 through 3 typically had maybe 1 or less comorbidities and minimal barriers to care. And so those 1 through 3s would remain with their PCP. Those that were scored 4 through 6 typically had multiple comorbidities and barriers to care. And so they were stratified that 4 to 6. So when we were looking at the patient's chart at the CCC, if they were ranked 4, they usually had less barriers to care. 6s typically had more. And so it was easier to identify the type of need that the patient had. In 2020, in September of 2020, we migrated to a new EHR, which was eClinicalWorks, also known as ECW. And ECW does not have a method to stratify patients. So patients began being transferred over to the CCC via referrals. And so it was a little bit harder to determine what types of barriers those patients had. In June of 2021, we began working on a pilot for patients. And so patients would be stratified with the PRAPARE form. So looking at numbers, we had 156 patients that were transferred into the CCC in 2021. And now looking at 2022, we've converted our care coordinators into community health workers, and the community health workers have began screening patients using the PRAPARE form at the health centers. And we're moving towards trying to integrate capturing social determinants of health data at all of our health centers, trying to find the most effective way. So why PRAPARE? So in June of 2021, we began plans for a pilot. And this pilot began because our care coordinators were spending a lot of time processing referrals and doing administrative tasks. And so they were unable to really focus on the patients that needed that extra help at the CCC. So the referrals were then reassigned to the medical front office staff. So the main people working on that was the CCC leadership team. So myself as the care management supervisor, our medical front office supervisor, our health center manager, our medical director, director of behavioral health services, all worked together to really establish a workflow that was going to work best for the patients. And so myself as a care management supervisor worked really closely with the front office supervisor to train our care coordinators and front desk staff so that the front desk would be able to take ownership of the referral aspect, leaving a little bit more time for the care coordinators to really focus on identifying patient barriers. So I worked on identifying barriers to develop an assessment to obtain for patients to be able to obtain care management services at the CCC. When speaking to our EHR specialist, we reviewed that the PRAPARE smartphone was already located in ECW, and it captured all the necessary data that was needed to identify patient barriers. So the care coordinators began screening using the PRAPARE in August of 2021. And this was done just with one team at the CCC. So it was a team of the care coordinator, the behavioral health provider, the primary care provider, medical assistant. And so the assessments were done either prior to or at the time of the medical visit, and it was typically done with new patients. So data was stored in the patient's chart because it was done via a smart form. And then the care coordinators worked on developing care plans for the patients to provide those resources. So the results of the PRAPARE were then presented in daily huddles with this team. And this was done with the PCP, the MA, the LCSW, and the focus really shifted on from just reviewing patient referrals to adding in discussion of social determinants of health. These identified barriers gave the medical and behavioral health provider additional insight when treating these patients. The care coordinator reported that patients have been more responsive and more compliant when following up on visits with these additional services. So with the CCC pilot, due to the success of the pilot, it was approved in January of 22, so this year. And so myself and the front office supervisor began recruiting for those medical front office care coordinator positions and the community health worker positions. And we began implementation just last month in April of 2022. So last year, the CHWs began asking the PRAPARE form questions, but since it was so new, we only had 81 patients that were screened in 2021. And currently in 2022, that data is not available. So our goal is really to perform those social determinants of health assessments at every patient that's at the CCC to identify why they're at the CCC. When using the PRAPARE form questionnaire, we did identify some challenges. So questions that would lead to uncovering some sensitive information. So the CHWs have completed de-escalation trainings, but don't have the education or background to address some of these questions. So sometimes that does come into referring a patient to a behavioral health service. But some of the questions, sometimes there's questions that are uncovered, and if the patient is asked triggering questions, it may lead to crisis intervention. And so if a behavioral health provider is on a pre-book or is already in with another patient, then it's difficult having that limited access to the behavioral health provider. Currently, the PRAPARE form is being done once per patient, and there's not currently a way to notify us to perform a reassessment. And then the CHWs have also had some difficulty completing the PRAPARE form questionnaire before or during a visit. So at the moment, the way we're doing it is the CHWs are completing these forms one-on-one with the patients at the CCC. So they're really asking these questions in depth to be able to get those answers from the patients and be able to provide them with the resources that they answer. So looking at the PRAPARE form questionnaire, these are a lot of the questions that the current CHWs are actually able to answer and address or provide an appropriate resource. So when it comes to the housing situation, so question 1, what is your current housing situation? We have a homeless community health worker. So because we're a primary care facility, we don't offer housing for our patients, and we don't have the resources often to be able to provide that housing. But we do offer services free of cost to our homeless patients. So if we identify that they're homeless, we're able to provide their medication and their treatments free of cost to them, but also get them set up with one of our on-site assisters to see if they qualify for Medicaid or Medicare services, which typically our homeless population does qualify for Medicaid. And then when referring them over to the homeless community health worker, we do let them know that we're not able to provide them housing, but we are going to provide them with the appropriate resources to get them housed. So our community health worker is out in the community finding housing lists to see where everything's at, reviewing applications with the patients so that we can get the patients filling out these applications and really explaining to them that this is really setting them up for their future. So we're not able to provide them immediate housing, especially when it comes to HUD housing. But if they sign up now, once those beds open up, then they're able to move into them. And then also looking at the local homeless shelters to see where they're able to be placed, especially when it comes to our women and children. We typically refer them to our place. Same thing with, are you worried about losing your housing? We refer them over to our homeless community health worker, who then sends them out to different resources. The third question is, what is your highest level of school that you have completed? When asking this question, we're able to identify what their health literacy is like. So most of our materials are at a 3rd grade reading level, but really then identifying how we're able to communicate with our patients and figuring out if it's health literacy, is that why they're not following through with their appointments? and then also be able to provide them community resources if they wish to go back to school, such as Rise Academy and Truckee Metals Community College, located here in Northern Nevada. Question number 4 is, what is your current work situation? So we provide them community resources as well, like Job Corps, Join Nevada, and then we can also refer them over to the Social Security office if they're needing to collect unemployment. And then we also refer them over to our Medicaid assisters to see what they qualify for as far as Medicaid. The 5th question is, in the past year, have you or any family members you lived with been unable to get any of the following when it was needed? So the list on there is food, clothing, utilities, childcare, medicine, and phone. When it comes to food, we do have our food pantries located at our Sparks and Wells location, and patients are able to pick up food once per week. And then we also have a mobile harvest van that comes to our health center at Wells once per month. So patients are able to pick up food there as well. And then we connect them to other community resources like Meals on Wheels and help them with that application process. When it comes to medicine, we of course refer them over to our pharmacy so that they are able to get their medications at low cost. And for our homeless population, they're able to get it free of cost. With phones, we do partner with SafeLink, and they are a phone service that's able to provide low-income phones. And then we also refer them to the MCO plans, and they've been really helpful with getting them set up with phones. We had Silver Summit at one point be able to provide phones for patients even if they weren't Silver Summit recipients. The 6th question is, has lack of transportation kept you from medical appointments, meetings, work, or getting things you need for daily living? So we did offer Uber Health when the pandemic started from 2020, and then we currently ended it in 2022 just because it was not financially sustainable. And so we've really looking at our resources in the community to get patients connected. So that's all of our Medicaid patients. We refer them over to MTM. Our patients that have a disability, and a lot of our patients that are at the CCC with those comorbidities qualify for RTC access. And so they're able to get that direct care, that curbside pickups to be able to go to their appointments. We also connect them over to access to healthcare, and then we work closely with their MCOs as well. Both Health Plan of Nevada and Silver Summit offer community health workers for their patients that experience social determinants of health and are able to provide either Uber or Lyft for patients that need to get to and from appointments. So we do rely on their MCOs and have those contacts to send patients over. So some of the questions that may be sensitive when asked by the community health worker are those with the social and emotional health and the additional questions on the PRAPARE form. So question 7, how often do you see or talk to people that you care about and feel close to? And then how stressed are you? Oftentimes they can answer yes, or they can answer prefer not to answer. And there are situations where this can make a patient uncomfortable and lead to that crisis intervention where sometimes we don't have that accessibility. But if they answer yes, we can always refer them over to a behavioral health provider. The additional questions: in the past year, have you spent more than 2 nights in a row in jail, detention, or juvenile correctional facility? Are you a refugee? What country are you from? Sometimes these questions can also be sensitive, especially with our patient population, because many of our patients are undocumented. And so sometimes it's difficult for them to answer this question because they don't know if it's going to be reported somewhere. So I have had staff feeling uncomfortable asking these questions, or patients asking why we need to know these answers. But there is an option that says prefer not to answer. And so we do communicate that with them. And then in the past year, have you been afraid of your partner or ex-partner? And so this can also be a triggering question that can lead to that crisis intervention that sometimes we don't have access to. So capturing social determinants of health and how we're going to try to do it outside of the CCC. So we're currently exploring how to address social determinants of health in all health centers, and looking at how we can do that everywhere, with either uploading a questionnaire to the patient portal or at the kiosks in the health centers to complete prior to visits in both English and Spanish, just because that one-on-one community health worker to provider that's offered at the CCC is not offered at all of our locations, but it is important that we capture that data everywhere. And then the Prepare Smart form does have the I choose not to answer this question. And so incorporating that into our kiosk and patient portal questionnaire, so that if the patient doesn't feel answering all the questions, they can add that option in and not answer it. And then we're able to track how many patients didn't want to answer that question. And then also developing a workflow when patients answer yes to questions is something that we're looking to figure out how to incorporate, whether it's if they answered yes to lack of transportation or lack of food, that we're able to give them an appropriate resource list or connect them to a behavioral health provider if they answer any of those questions at the end of the questionnaire, or even a community health worker. And so eventually the goal is to be able to offer a community health worker at all of our locations so that they can really work on addressing those social determinants of health with our patients before they end up at the CCC. And then identifying other social determinants of health questionnaires to compare them to the Prepare to ensure that CHA is using the most appropriate method for capturing social determinants of health data for the population, and then gathering feedback on whether we address these patient barriers for the patients. So one of the reasons I really wanted to bring this up and present here and hear from other health centers is looking at have other health centers been using the Prepare form, what their experience has been, and then if other health centers are using other questionnaires and some of the pros and cons of using those other questionnaires.
Thank you so much, Sandy. So since you said that, let's post a poll to see where everyone is on if they have a social determinants of health screening or assessment tool. So you should see the polling on your screen right now, and we can get that answered. And it looks like we had a lot of couple questions come up for you too, Sandy, in the chat box. So while we get the poll running, do you first question, did your primary care providers stratify all patients?
So no, we weren't able in that pilot to stratify all patients. It was patients that, do you mean out to get a referral into the CCC or with the Prepare form? Sorry.
That's a good question. What? It wasn't clarified. Why don't you share both if you stratify for both?
So outside the PCPs, we're stratifying patients before. And so now when a patient is being transferred into the CCC, it's usually when the provider is able to grasp if they have any comorbidities or any barriers to care. And then as far as the Prepare form, we were only able to complete 81 questionnaires last year for our patients. And so we're looking to make sure that all of our patients at the CCC have the Prepare form done. So it's still really, it's in its early stages for sure.
You, and another question that came up is, do you receive funding for medication costs for your uninsured patients with homelessness?
Yes, we do. We do have a grant to be able to cover those homeless services.
Okay, thank you. Now, it looks like we have several questions too for Hope Christian's respite RCC care. So I'll scroll up to them so we can start answering those too. And the first question that we saw that hasn't been answered yet is, do you bill the respite visit as an office visit?
So that so it's I'll answer it from like a billing standpoint. Is it is primary care visit, so there's not necessarily a quota respite visit, because I guess a respite care is the time that they are admitted from the time they're discharged would be their time at respite, and so whenever a primary care visit is completed, that's whenever the bill is generated. Dr. Cruz, do you have more insight on that?
The other question that came up is, or comment and question is, it would be interesting to see if you can get a Nevada Medicaid to eventually update their state plan section on 1915 to cover this under rehabilitation. Can you currently bill for behavioral health for any psychosocial rehab?
So at this time, we actually are not, we do not have a behavioral health provider, and so we're not credentialed in behavioral health. And so at this time, no, but we are actively looking for a person who will fit well at Hope.
And do you currently receive HCH funding from HRSA?
Not for recuperative care services, no, we do not. Our funding is solely from the city of Las Vegas currently.
And for your patients in the RCC, what is the average age of your patient? Are they a lot of them under Medicare, SSDI, or SSI?
Steve, I think you're going to be able to better answer that. Like, what's that age range, and yeah, what Medicare eligible and SSI? Oh, you're muted, Steve.
Yeah, here we go. Yeah, good question. Medicare, we have a higher Medicare rate at RCC than any of our other facilities. Same thing with Medicaid. And the Medicaid, the MCOs are across the board: Molina, Silver Summit, Anthem, and HPN.
So more questions coming in. Is your partnership with hospitals, is there an expectation from the hospital to reserve a specific number of beds for patients who are not discharged?
Yeah, we have meetings going to be set up with the city and the CEOs of the hospitals. Today, there is no expectation of holding beds for them or not, and we really don't want to get into that. We want to contract for the beds, but I think we want to stay away from restricting ourselves by reserving beds for hospitals. So it's basically been a first come, first serve.
So partnerships are actually what we're currently working on. We don't have existing formal partnerships with MCOs or hospitals right now.
And for your patients currently in the RCC, what is their average length of stay?
I think it averages just over 30 days, and it varies. There are a couple extremes. There are a few patients that have been in there 7, 8, 9 months because we can't place them. They're healthy, they're ready to go, but there's certain restrictions that keep them from being placed in permanent housing, and we will not release them into the streets. But for the most part, 30 days, 31 days.
And it looks like we have another question on specifically the Medicare Advantage plans and the Medicaid MCOs. So they're not currently interested in partnering with you to support reducing costs?
I wouldn't say they're not interested. I think we just haven't got to that point to sit at the table and discuss it. I'm pretty sure they will. I'm pretty sure they are interested, but this is all new to us and for them regarding the respite.
Thank you. Keep the questions coming in too, and just for everyone to see the results from what other folks are using for social determinants. It looks like several of you have said that you are using a tool, and it looks like one of the main tools that were noted was a PRAPARE tool, and some are not sure they're not currently using a social determinants of health tool. And moving 2 slides ahead, and I'm going to have Dawn speak on the value of collecting this information.
Great. Well, thank you, Hope Christian and Community Health Alliance. That was really informative and inspiring. So thank you for all your great work. Just a couple of quick reminders or connections, since all of you are federally qualified health centers. This first slide is just to remind you that in the Uniform Data System, or your UDS, you've always had the health, well, not always, but for many years, you've had a health information technology capabilities form that you fill out, and you're required to answer those questions. Quite a few questions were removed this year for calendar year 2022. But these questions that you see up on the screen, we just wanted to call your attention to. I believe you did have to report on these in some fashion last year. But as you can see, how many health center patients were screened for social risk factors, which standardized screener for social risk factors, if any, did you use? And then of the patients that you did screen, what's the count based on food, housing, financial, and transportation? And so I think this, along with the recent release of the service area competition, the SAC announcement for fiscal year 23, and the fact that in that SAC notice of funding award, it talks a lot about social determinants of health, that we're going to see more emphasis on this from the Bureau of Primary Health Care. Next slide, please. So when you, I guess back one slide. So when you think about, the UDS tables, and I think you need to go back one to the enabling slide, you know, there have been, you've reported on social determinants of health indirectly through the enabling service categories that you have. So, you know, in table 4 for UDS, you're looking at the number of patients by some of the social determinants of health, such as housing is there, or homelessness needs. Table 5, you have things around the number of visits, the number of patients in various categories like eligibility assistance, and case managers, outreach workers, transportation personnel, and things like that. And then, of course, on table 8A, you have your enabling services broken out as well, and you're reporting on that. So again, we just wanted to remind you that there's a huge connection to the work that you're doing around social determinants of health and enabling services and what HRSA is asking of you. So we anticipate it will continue to increase, and we'll all, I guess, learn together how that unfolds moving forward. So yeah, thank you.
Okay, thank you, Dawn, for reviewing those. And to follow up again on some of the things that we wanted to go over is, for those of you who are currently screening, who is screening these on these social determinants of health? Is it your enabling service staff, or is it your clinical staff? And if anyone, has anyone been facing barriers? And we know that Sandy, you mentioned that there are current barriers with using the PRAPARE tool. Have you been exploring other tools, or has anyone else been exploring other social determinants of health screening tools too?
Yeah, Rim, I'll speak up. I think one of the difficulties that we've run into the last couple of years is the social determinant screening questions and their integration into the EHR. So it's seamless and it's not duplicative work. I think that is the biggest challenge. And then extracting data. If it's a standalone PDF, you can't extract data. So those are some of the challenges that I see, at least with what everybody I've spoken with.
Ali agrees that they run in with the same challenges too. Thank you for voicing that. Now, the other barrier that we know is that sometimes there are a lack of resources to be able to share, and it looks like Sandy and her team have been able to stratify what resources are available within the community to address each and every type of social determinants of health. So what currently are some of you having struggles with resource-wise to connect your patients to in regards to food, housing, financial insecurity, or transportation? Thank you all for engaging in the polling as they come up.
Rima, I'll comment on this a little bit. I don't know if we have any of the challenges for resources. I mean, obviously housing and food are always issues, but I think there's resources there. The problem is getting the patients connected to the resources. They don't have working mobile numbers, they don't have access, and then getting them to go to a financial place for help with financials, or getting them to the housing centers to get them. It's the transportation to get there. So I think it's a combination of many of these. I don't think you can say it's just one. I think that there are available resources, but it's the accessibility to get them to them in a timely fashion.
Has anyone, from what JC shared, anyone has found new ways of connecting and making sure that continuity happens for your patients? Ellen, you commented that you've been focused on intensive case management for that continuity of care. Now, another thing that we're not going to step into too much today, but we do have, and it looks like Samantha's looking at adding more CHWs into their workforce too, is utilization of the Nevada Community Connector, which you can, again, find on the NVPCA website, but that is a resource for you and your team to utilize too. And everyone, we can continue talking about that further if you have any questions about how to use the Nevada Community Connector. where that the Hope Christian team is utilizing it or starting to utilize it, where the other centers too are getting it into their workflow?
We're currently using that as well, Rima.
Oh, okay. Thanks, Sandy.
Yeah.
Well, I look at these different, when we're looking at social determinants of health too, who do you screen right now? From what we've seen with health centers, it's looking at specific groups of patients before disseminating it to all patients, or it's looking at different special populations, patients with different comorbidities to get it started, because as we know, you will be having to report these numbers out to HRSA in the future. For those of you who are screening all patients, looks like we have several folks who have shared that they are. What was the decision process in that, and how long have you been screening all your patients on the social determinants, and what platform are you using? Are you using a kiosk or are you using iPads? So while you think about that, another question I want to pose is, what other social determinants of health innovations is anyone doing today or planning to do in the future that they would like to share? We do have many different health centers joining us today, so if you'd like to share what innovative practices you're doing.
Rima, I'll comment on this. I think right now a lot of our focus is just getting our patients back into the clinics. I don't know if others would say that or not, but I really think that that's still a challenge, is getting patients in, period, and to get them in for social determinants would be great. But we've all fallen down on immunizations, at least from what I'm hearing, and everything else because of the pandemic. And still, even now we're in the pandemic, epidemic, whatever it is, we're still having problems getting patients to come in. So it's not just about us being able to access, or get them the things that they need, but it's getting them into the doors.
Has others faced a similar challenge what JC is sharing, getting your patients into clinic?
I would agree. I think especially with our patients that a lot of them may have lost housing during the pandemic. And so just getting them reestablished because they weren't coming in, and then CHA did offer telehealth visits for a while, and now we're trying to get patients back into the health centers, and that can pose an additional barrier to the patients that were relying on those telehealth visits as well. So I think it's just getting everyone back to normal, and what this new normal is.
Well, we definitely appreciate all that each single health center, what you're doing right now to support your patients in this realm. And again, we thank you all so much for joining us today. And with that shared, I will be putting in the evaluation poll into the chat box. That way folks can, if you have the chance to quickly take 2 minutes of your time to complete the evaluation, that'd be wonderful, because we want to continue on this conversation on social determinants of health. And if there are any topics that you want to have us connect you with, or if there's any more trainings that you like on specific factors of social determinants, please let us know. Thank you for putting this together, Rima. Yeah, if there's any continuing questions for our presenters today, you can always email it to us. My emails are naik@nvpca.org. And with that shared, we thank you all so much for joining us, and we'll follow up with the slides for everyone to have for your records too.
Thank you, everybody. Thank you, Rima, Dawn, Karen.
Thank you all.
And,
have a great day.
Take care. Bye-bye.
Thank you.
Thank you.
Bye.